Dr. Vivekanand Gajapathi sir. I am Satish Rama Joshilkar from Zydus. Would like to welcome you all on this scientific platform called CLEARTalk. On behalf of Zydus Life Sciences, I would like to extend my most sincere gratitude for your presence in this scientific webinar. Talking about a brief of CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia. As you are aware that 8 out of 10 Indian patients are having uncontrolled LDL cholesterol, and the most recent development in the field of dyslipidemia management is Bemdac acid as an add-on choice for LDL cholesterol management. Recently in ACC, American College of Cardiology, late breaking clear outcomes trial was presented, and this was one more addition to our scientific knowledge and update. So we have one of the best faculty and speaker for today, Dr. Vivekanand Gajapathi sir. I would like to give a small brief introduction about sir. So I'm sharing slide. Sir is MD DM Cardiology, Chief Interventional Cardiologist at SDM Narayana Hrudayalaya Hospital, Dharwad. Sir has many affiliations to his credit. He was Associate Consultant in Department of Cardiology, Aditya Birla Memorial Hospital, Consultant Cardiology, Usha Malapudi Cardiac Center, Hyderabad, and he has many publications to his credit. I mentioned one of the few of the important publications. So without wasting much of our time, would like to hand over this session to Dr. Vivekanand Gajapathi sir. Thank you so much for being on this platform.
Thank you, Mr. Satish. At the outset, I would like to thank Zydus for this opportunity. Can you see my slides now?
Yes, sir.
Okay.
Visible.
So I will be discussing about bempedoic acid with respect to the new clear outcome trials. So we all know that LDL cholesterol is the reason for atherosclerosis, and lower the LDL cholesterol, lower the adverse cardiac events, and it would be better if it is sustained for a long time. And there is a relative risk reduction of about 23% with each 1 millimole per liter of reduction in LDL cholesterol. That is about 38 milligram percent reduction of cholesterol, where we can reduce major adverse cardiac events by 23%. And this reduction gives more CV event reduction if it is sustained for many years. Suppose if the patient maintains this 1 millimole per liter reduction for 1 year in a clinical trial, we are going to observe around 11% reduction in risk. If it is for 2 years, almost 24%, 3 to 5 years, almost 33%. So longer the better, lower the better. But in the management of dyslipidemia, when it is high on the priority and statins are the first line of therapy, we have two questions. Do all statin users achieve LDL goal as per guideline recommendations? Second question is how to achieve this LDL cholesterol target after maximally tolerated dose of statins. So first we'll start to try to answer this first question. Do all statin users achieve LDL cholesterol as per guideline recommendations? If you see go through the ESC guidelines 2019, they are more stringent than 2016 guidelines. For low risk, we try to maintain LDL less than 115 milligram. For moderate risk, it is now 100 milligram percentage. For high risk, we should reduce LDL below 70 milligram percent. And for very high risk patients, it should be brought less than 55 milligram percent. So as the CV risk increases, there is no need to reduce more LDL cholesterol. Earlier, when the target was around 100 or 70, it was easy, but it is very difficult to achieve target levels up to 55 milligram percentage. And some Indian guidelines also recommend LDL target less than 35 or 30 milligram percentage in extremely high risk patients. So based on this revised ESC 2009 guidelines, which were published almost 4 years ago, let us see how many patients do have controlled LDL cholesterol. To address this one, the Vinci study was conducted across Europe, and it was a cross-sectional observation study of patients prescribed lipid-lowering drugs for primary and secondary prevention, and almost 18 countries of the Europe were involved. almost 6,000 patients were studied, 3,000 were primary prevention, and almost 3,000 patients were in secondary prevention trial. So the basic objective was to evaluate impact of ESC 2019 dyslipidemia management guideline on present LDL cholesterol achievement. So according to this study, almost 27% of the patients were eligible for receiving high intensity statin. But unfortunately, only 30% achieved lipid goals with this high intensity statin. And in this study, 37% of patients were eligible for receiving high intensity statin in a very high risk patients. But in these very high risk patients, only 22% of the patients achieved a lipid goal of less than 55 milligram percentage with this high intensity statin. So there is a lot of gap between the practical aspects and guideline directed medical lipid management. And second question, how to achieve this LDL target after maximum tolerated dose of statin? Suppose we have used atorvastatin 40 mg or 80 mg. If it is not achieved, how to achieve this LDL cholesterol target? So for all ASCVD patients, we check baseline LDL cholesterol, and then initially target to reduce LDL cholesterol with statins and try to bring it less than 50%. So if you use in ASCVD like acute coronary syndrome, stroke, and PAD, if you use high intensity statins, you can decrease LDL by 50%. If you want to decrease it more, you can add ezetimibe, which will give additional 15% reduction. Suppose if you add bempedoic acid, you can achieve another. If the patient, if you combine a high intensity statin with bempedoic acid, you will achieve similar reduction, almost 65%. That is another 15%. But if you combine both everything like high intensity statin, bempedoic acid, ezetimibe, we can achieve another 25% reduction. And when we add PCSK9 inhibitors, we can definitely bring it to the lowest levels. So the requirement is even more in patients with familial hypercholesterolemia, because they will be having very high LDL cholesterol levels, and the higher the LDL cholesterol levels, it becomes even difficult to achieve these target values. And many patients come with a complete statin intolerance. Earlier we had very few options. Now we can use bempedoic acid and ezetimibe combination, which can reduce LDL up to 36%. PCSK9 inhibitors alone can reduce LDL to 50 to 60%. So ezetimibe plus PCSK9 inhibitors, 70%. If you combine all these bempedoic acid, ezetimibe, and PCSK9 inhibitors, we can reduce LDL up to 80 to 85%. So high intensity statin, although it is a theoretically correct, but has got a very low adherence practically, which leads to higher major adverse cardiac events. In an observational study of 23,000 patients post ACS who were prescribed high intensity statin after index event, only 66% were taking, so almost 66% of the patients were not taking high intensity statins after discharge, and 50% had drug interruption within first month. And this non-adherence leads to strong association with high risk of mortality by about 16%. So now we have a newer drug, bempedoic acid, which is the ATP citrate lyase inhibitors. It is a first-in-class LDL lowering agent, which are different mechanism of action. So it was approved in 2020 in US and Europe, and even it's approved in India by DGCA also. The main indications are to reduce uncontrolled LDL in patients who already received maximally tolerated dose, or in patients with familial hypercholesterolemia, mixed lipidemia, high risk of ASCVD patients also we can use. And second important indication is statin intolerance, or in whom statin is contraindicated because of several other reasons. And the dose is 180 mg orally with or without food. So if you see the mechanism of action of cholesterol synthesis, this bempedoic acid acts one step prior to that of statins. Statins, they inhibit HMG-CoA reductase inhibitors. Bempedoic acid is converted to bempedyl-OA, is an active drug by acyl-CoA synthesis, very long chain acetyl citrate lyase, and this enzyme is not present in the skeletal muscles. That's why muscle side effects are not seen. The other problem with this bempedoic acid is there is a slight increase in uric acid and creatinine levels due to its mechanism of action. So half-life is about 21 hours. 70% is excreted through kidneys, 5% through the gut, and less than 2% excreted unchanged through the kidneys. So most importantly, in a renal impairment, there is no dosage adjustment is necessary, although we don't have much trials in end-stage renal disease. And in hepatic impairment also, there is no dose adjustment is necessary, because but there are no studies in advanced liver disease like child-pugh class C. We need to assess uric acid whenever it is clinically indicated, because there is an increased incidence of hyperuricemia and gout. We need to be careful in patients who are more than 65 years of age, especially they are taking corticosteroids or fluoroquinolones if they have renal failure or history of tendon rupture, because there is a chance of tendinitis or tendon ruptures. And it is not indicated in patients who are pregnant and those are breastfeeding. So if the patients are taking simvastatin and pravastatin, better to avoid bempedoic acid. Anyway, we are not using these drugs nowadays. So this CLEAR outcomes trial is a CV outcome trial with bempedoic acid in patients who are statin intolerant. It was published in, it was presented in the ACC 2023 ACC meeting and simultaneously published in NEJM. So it's a global cardiovascular outcome study in patients who are statin intolerant and with elevated LDL cholesterol. They included both primary prevention and secondary prevention patients who had elevated LDL and statin intolerance. Almost 7,000 patients were received bempedoic acid and 7,000 patients received placebo. So almost 14,000 patients were involved and the median follow-up was 40 months. So they wanted to study 4 component major adverse cardiac events in the form of CV death, non-fatal MI, non-fatal stroke, and coronary revascularization. So we all know that statin intolerance is very common. Almost 15% of the treated patients, they don't receive statins because of intolerance, like muscle pain, liver side effects. And we have bempedoic acid in such patients, and it is approved for LDL lowering. But earlier, CV outcomes were not assessed. So when they studied this primary and key secondary endpoints, the primary endpoints were 4-point MACE, that is a non-fatal MI, non-fatal stroke, cardiovascular death, and coronary revascularization. Secondary outcomes were 3-component MACE, that is except coronary revascularization, they studied MI, stroke, and CV death. They also studied individually the fatal and non-fatal MI, coronary revascularization, stroke, cardiovascular death, and all-cause mortality. So if you see the demographic data, it was almost equal. Statin, low-dose statin were used almost in 22% of the patients. Almost 11% were using ezetimibe. 45% were diabetics, and almost 30% of the patients were in the primary prevention arm, 70% in the secondary prevention arm. And average cholesterol, LDL cholesterol was about 140 milligram percent. So when you consider 4-point MACE, there was a 13% reduction was there. 3-point MACE, that is except coronary revascularization, 15% reduction was there. And fatal and non-fatal MI were reduced by about 23%, and coronary revascularization was reduced by 19%. So all these were statistically significant. So among statin intolerant patients, treatment with bempedoic acid was associated with lower risk of 4-point MACE by 13%, 3-point MACE by 15%, MI by 23%, and coronary revascularization by 19%. So LDL was reduced by about 21%, which is compatible with the older studies, pharmacokinetic studies, and HSCRP was also 22%, which was already confirmed in the older study. So coming to the adverse side effects, the adverse side effects worthy of mentioning are hyperuricemia and gout. Slightly increased in patients. Hyperuricemia is 10%, in bempedoic acid arm, 5% in placebo arm. Gout is slightly increased, like 3.1% in bempedoic acid arm and 2.1% in placebo arm. Apart from that, everything, all the side effects were almost similar, and myalgia was less. So they concluded that bempedoic acid becomes the first ACL inhibitor and first oral non-statin to demonstrate statistically significant reduction in MACE4 events in patients with who are at high risk of CVD with documented statin intolerance and elevated LDL cholesterol. So it is an effective alternative for statin intolerant patients, because with the clear outcome, we now are very sure that it is well tolerated, both in patients who are at primary prevention and secondary prevention patients who are unable or unwilling to take statins. And there is a significant LDL reduction by about 21% and HSCRP reduction by 22%. However, there is a small increase in the incidence of gout and cholelithiasis. And the primary endpoint was reduced by 13%. Secondary endpoints like 3-component MACE was reduced by 15%, MI was reduced by 23%, and coronary reacceleration was reduced by about 19%. So bempedoic acid is an effective approach to reduce major adverse cardiovascular event in statin intolerant patients. Thank you.
Thank you so much, sir. There are few queries in the chat box. Sriram Herlekar sir is asking about, can saroglitazole be used to bring down LDL cholesterol, and is it indicated only in NAFLD? This is not related to the topic, but he has asked this question.
Saroglitazole is basically to reduce triglyceride levels, especially in a diabetic patient, and it's also used in a non-alcoholic fatty liver disease. So I don't have much experience with reduction in usage in non-alcoholic fatty liver diseases, but I used saroglitazole in patients with increased triglyceride levels, especially in patients with diabetes, even after statin treatment.
Next question is Dr. Suhasini is asking about how much LDL, because you initially talked about 2019 guidelines, LDL cholesterol reduction and 55, but how low you are going in your clinical practice, how much low one can go, and is it safe?
Yeah, usually I start with atorvastatin 40 mg or 80 mg in patients with acute coronary syndrome or the high risk patients, and repeat lipid profile after 1.5 months to 2 months. If LDL reduction is too much, less like the 30s or 20 milligram percentage or 10 milligram percentage or even single digits, we have not achieved any single digit till now. Usually I don't alter the medications. Usually I try to continue the same dosage unless and until it is contraindicated. So there is no proven adverse cardiac adverse side effects of very low LDL cholesterol. Even in many PCSK9 inhibitor trials, when single digit LDL cholesterol level was achieved, there were no neurocognitive side effects or any other side effects.
Fine, sir. Thank you so much. Somebody is asking about, my patient is a hypertensive patient, and he is also having diabetes mellitus, but his LDL cholesterol I am targeting is 100 milligram per deciliter. Is it fine to target this, or should I bring it low to this level?
Yeah, usually in my clinical practice, I use ECC guidelines. So for all diabetic patients more than the age of 40 years, we need to use statins, moderate dose statins. Usually I use 10 milligram of atorvastatin in uncomplicated diabetic patients. Suppose if the patient is having a history of coronary artery disease, we need to be more aggressive, like we use 20 milligram or 40 milligram. So based on this, if you see the ESC guidelines, they categorize the high risk, very high risk. We can go through it, and we need to see where our patient fits. So with that, usually I tend to reduce LDL cholesterol to less than 70 in patients who are for primary prevention, or for secondary prevention, I try to reduce it less than 55%, because we can't go through these guidelines every time. But it's better to target the LDL cholesterol as low as possible, below 70, and 55 milligram percentage or less in secondary prevention patients. If the patient had recurrent CV events like had stroke, MI, repeated MIs, so we need to be more aggressive and try to reduce LDL cholesterol to even lower levels up to 30 milligram percentage.
Fine, sir. Thank you so much. Next question is about the LDL cholesterol reduction only, but he is asking about without increasing the dose of statin, can I use bempedoic acid or ezetimibe, or because there are chances of muscle problems, symptoms, myalgia. So can I, without increasing dose of, can I use bempedoic acid or ezetimibe?
We can use, but if you see the guidelines, they all ask us to use maximally tolerated statin dosage first. So if you see the old guidelines before this clear outcome trials, they all recommend to use maximally tolerated statin dose plus ezetimibe if necessary, if LDL goal is not achieved. And even if this is not achieved, now we have option of using bempedoic acid. But in my clinical practice, usually I start with high dose statins. And if the LDL targets were not achieved, like if LDL level is in 110, 120, there's no point in wasting good time in introducing first ezetimibe, waiting for another 2 months, and then adding bempedoic acid. Usually, I start with the bempedoic acid plus ezetimibe combination, and it is also recommended by the many experts who presented this bempedoic acid trial, clear outcome trial. Because with the combination of bempedoic acid and ezetimibe, we can achieve LDL cholesterol alone by 40% without statin. So there is no, especially in patients, such patients with the high risk of adverse cardiac events like post-MI, post-acute coronary syndrome, or post-stroke, there is no point in waiting for months together to achieve this LDL cholesterol. We need to bring it as early as possible.
So one question is that I am worried about GOT or tendon rupture. So is there any comment you are having on this?
Yeah, many many patients on statins, they are prone for tendon rupture, especially in the elderly people, and especially if they are many patients who are already taking corticosteroids, they are prone for tendon rupture, and elderly people, they are prone. If the patient is having already tendinitis and already on fluoroquinolones, we need to be careful. Anyway, we as a cardiologist, we don't examine and ask for such history. But when we are using bempedoic acid, we need to be about careful about these three things. One is uric acid, second is gout, third is tendon rupture and polylithiasis. So we need to monitor these four new symptoms.
Very well said, sir. And Dr. Prabhaya is asking about mixed dyslipidemia. How do you approach? Is statin enough? Anti-triglycerides have high toxicity. Tolerance is less. So
Yeah, exactly. So in patients with mixed dyslipidemia, suppose triglyceride layer around between 200 to 500. So if the triglyceride levels are more than 500 or more than 800, so our first priority becomes to prevent pancreatitis. So we are not worried about cardiovascular events. First, we need to, usually use fenofibrate, which are recommended to reduce the triglycerides below 500. Once the triglyceride are reduced below 500, then our focus shifts to reduce this adverse cardiac events. We need to protect the coronaries from this deleterious effects of intermediate density lipoproteins like VLDL and all, because they are like LDL, they are very much. So in that case, we use statins. Suppose if the triglyceride levels are below 500 from the beginning, I usually use high dose statins first and check triglycerides after 2 months. We also advise the patients to reduce fat intake and go for regular exercise, and also need to control diabetes, because well controlled diabetes is also, we can with a well controlled diabetes also we can reduce triglycerides, and we also need to look for hypothyroidism in such patients. So once we have started statins like 20 mg of atorvastatin or 40 mg of atorvastatin, and still triglycerides around 200, we need not bother about that triglyceride. We need not add any other agents, because if you add statins plus fenofibrate, the chances of myalgia and hepatic problems will be more. So our main target in mildly elevated triglyceride is to reduce LDL cholesterol.
Hope this question has been answered. And then this was the last question which I received on my chat box. Sir, from my end, I would like to ask one question: is like how you define that patient is having statin intolerance? How you clinically define patient is having statin intolerance?
Many patients in my clinical practice, I don't discuss about the side effects, because once we tell that the statins cause the muscle side effects, even slight pain, any leg pain or calf pain, they stop these statins. And even if these patients go to their general family physicians also, they usually tend to stop at the earliest. So if the patient is having this statin related muscle side effects, first we need to check whether they are really statin related muscle side effects or not. And we can initially reduce the dose. But if the patient is really intolerant, we can stop it, wait for 1 or 2 weeks, and challenge with a lower dose, or we can change the this one drug. Like if the patient is taking atorvastatin, we can use a rosuvastatin, or in fact even you can use a pitavastatin. So we can change the drugs and re-challenge it before declaring that the patient is completely statin intolerant. But sometimes, however, patients they refuse to take statins altogether, fearing about these side effects. In such patients, we can use this bempedoic acid and the ezetimibe combination.
Thank you so much, sir. This was a very wonderful presentation and talk. You addressed all the queries which we have came across, and hopefully audience must have got their answers from sir's point of view, and in his expertise, in clinic expertise and his experience will definitely help us in treating day-to-day patients in our clinical practice. Sir, any final closing remarks you would like to add before we close?
Yeah, definitely. In our clinical practice, we don't follow these LDL levels regularly when the patient comes for follow-up. Whenever the patient comes for follow-up, we advise them fasting lipid profile during next visit, but very few patients get fasting lipid profile. So fasting lipid profile is not necessary for following these patients. In my clinical practice, I usually get lipid profile whether patient is fasting or not, and follow these LDL levels. We need to see that what is the LDL levels during follow-up. We need to assure the compliance of the patient, whether it is taking statins or bempedoic acid or not. And we need to also see whether the patient has already achieved a goal or not. So we need to maintain the follow-up of these patients. If the patient has not achieved LDL target, we need to escalate the medications. Suppose if the patient is taking only atorvastatin 10 mg, we can increase to 20 mg or 40 mg, or add bempedoic acid or ezetimibe. So there is a lot of clinical inertia from our side. We don't check follow-up cholesterol levels. We just start some statins like 20 mg or 10 mg and forget it. That should not be there.
Thank you so much, sir. Would like to request our regional head, Mr. Mrityunjay, to give vote of thanks. Thank you.
Sir, Gajapathi sir, really it's a wonderful session what we had. I hope Satish, more than 20 doctors that attended.
I'm just checking it out. It's around 24.
Yeah, 24. Great, sir. Actually, we are worried about because already almost all doctors they are not able to join for online webinar. So first time we are doing it after COVID, sir. So definitely session what we had, and you have covered all the points, sir. It was indeed pleasure and honor having you in this event. We on behalf of Zydus Lifestyle, sir, we would like to extend our sincere thanks to you for your comprehensive session. And we are sure our delegates would have definitely got enlightened regarding the usage of bempedoic acid, as you have covered all the possibilities aspects in your session, sir. At the same time, sir, our Prabhaya sir, but also joined, sir, your close friend, and Dr. Harlekar sir is a very interested in the scientific session. At the same time, we would like to thank all the delegates for their presence and the patient hearing, sir. Thank you all once again.
Thank you.
And thank you so much, Satish ji, for your time on behalf of Hubli Division Medica. Thank you, sir.
Yes.
Thank you so much. Thank you so much, sir.
Thank you.
Thank you, sir.
Thank you. Thank you,
And
Anand.
Okay.
bye.
Thank you. Bye.
Take care.
Thank you.